Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Hospital in New York City. My name is Pedro
Why
Moreno.
are
I'm
you coming?
interventional
No.
cardiologist, and I will be your moderator today. We would love to hear from you. So please send us your questions either from the website or from YouTube. Remember, all our cases are already available for your review at ccclivecases.org. And now, let me introduce you for a fantastic case to the heart structural team with Dr. Sharma, Dr. Kinney, and others right now.
All right. Uh, Good morning, Pedro, and to all our viewers of the structural live cases. And very unusual case, that is the Trans-Carotid. As you know, the journey of the tower started where only one trial, in the first trial, in partner 1A, we had a double incidence of stroke tower compared to surgery, but that using the earlier Edward SAPIEN valve, which it required 20 to 24 French sheet. But since then,
Is there a
all the
lap
tower studies have shown equal or maybe slightly lower stroke rate with the tower versus surgery. So this is the case of the Trans-Carotid. Over last few years, there are a lot of cases have been published, a lot of reports have been published about the Trans-Carotid and appropriate cases. We had done about 4 or 5. We did one live case also, and this is where we are now today to show to our audience the Trans-Carotid. So let me just tell you through that the partners in this basically that myself, Dr. Kini, Dr. Khera, Dr. Tang, our surgeon, and I would say the main MC of the event today is Dr. Remy Tadros, who is going to expose this carotid and do this tower along with our two fellows, Negar and Anup, and rest of the staff and our anesthetist, Dr. Luis, and then Laracus on the echo. So with that note, we wanted to just quickly show the case before we go on. Show the slides, please, and then we'll go to exactly what is going on now. These are our involved faculty with Joseph Laris as the cardiac anesthetist, and so this will be a Trans-Carotid tower with 26mm SAPIEN-3 Ultra Valve. This patient is an 88-year-old. This is our 52nd episode of the structural case with the patient presented with class 3 symptoms of shortness of breath and dizziness and multiple issues as you can see there. PAD, abdominal aortic occlusion, although except CAD is non-obstructive, and patient is on good medical therapy. Creatinine is all right, and echo showed severe aortic stenosis, and we'll show that live echo. Can we show the echo, please? Yeah.
11. Here. Mild mitral regurgitation, mild minimal tricuspid regurgitation, no thrombus in the left lateral appendage. As you can see, the aortic valve on zoom, thickened calcified leaflets, no much motion, minimal aortic regurgitation.
Don't use this.
Explain, as you can see, severely stenotic aortic valve, no minimal AI. This is a deep gastric view to get the gradients. You can see thickened leaflets, no much motion. This is the TVI for the LVOT 13. And the peak gradient here is 3.5 velocity, 49 peak, 29 mean, based on the continuity cohesion. Aortic valve area 0.6 centimeter square, stroke volume index 29 ml per meter square, low paradoxical, low flow, low gradient aortic stenosis, most likely because of the severe hypertrophy and small ventricle. This is a 3D image. Dr. Tang likes these pictures.
Yes.
The area by the 3D is 501 millimeter square. I think the same they got by CT. And the circumference 8.5 centimeters. The maximum diameter 2.8, minimal diameter 2.2 of this LVOT. As you can see, thickened ventricle, no pericardial effusion.
Okay.
Long axis view, deep gastric view, thickened ventricle, normal ejection fraction. Thank you very much.
Okay. From your point of view, Stam, that it's a routine severe aortic stenosis case, maybe some low flow, low gradient, and hypertrophy and okay ejection fraction, right?
Yes, okay. Ejection fraction normal. Just if the patient becomes hypotensive or something after the valve is deployed, just to know to give some fluids for resuscitation.
Beautiful. Okay. So as you remember that at resting, these are the numbers earlier, but now lower every time patient under anesthesia, we know the numbers and gradients goes down, which is expected. So this is about CTA. Who wants to talk about it?
Yeah, I can talk
Yeah.
about it, sure. Good morning, everybody. So you can see this annulus is pretty benign. It's kind of true size for 26 SAPIEN-3 Ultra. LVOT is a bit smaller, so it looks hypertrophic LV, so we have to be mindful of the deployment depth and also risk of conduction. Next slide. STJ sinuses are very generous, no issues there. Next slide. You can see the left main height is good, right main height, right corner height is also good, no issues there either. Next slide. So a little bit horizontal aorta, you can see 60 degrees, but should not be an issue with a carotid approach. Next slide. And you can see very calcified aortic arch all the way to descending, right? It's like porcelain. So that's why I think even with transfemoral is feasible, it would be risk of certainly aortic emboli. And you can see now the access anatomy from a femoral standpoint is not really feasible. There's no runoff beyond the distal abdominal aorta. Next slide.
Yeah. So this basically is the case with the STS risk mortality is 3.59 and evaluated by the heart team, and because of severe PAD and aortic occlusion, decided Trans-Carotid, and that's where we are with a 26mm SAPIEN-3 Ultra via right carotid artery cut down, and now maybe we can focus more on Dr. Remy Tadros and tell us where we are in this
C1 times 2
issue now. So we can focus the camera, top camera to that side, the exposure. So Remy, tell us, I know you have been involved in few of, help us out in this carotid cases, how this case is proceeding so far.
So far, it's going really well, Dr. Sharma. The challenges with this case, as has been outlined already, is the access, the transfemoral access is not possible. And as you outlined, the stroke rate from transcarotid access is actually lower than subclavian access. The key is planning. We get CTA of the head and neck on all these patients. We assess the circle of Willis, which is intact in this patient. We ensure that there's adequate flow to the brain from both sides of the carotid circulation, both anterior and posterior. And so the key here is protection of the brain. In this case, we exposed the cervical carotid artery above the clavicle. We controlled the vessel distal, bring up the blood pressure to help perfusion of the brain. We clamped the vessel distal. Once the vessel is clamped distally, the brain is protected. And then we access, of course, after hypertension, we access wire down. And in doing so, we protect the brain. And that's the idea here, is that we're constantly thinking about cerebral protection.
Okay. Now, let's say if you have both carotids are good, right versus left, what will be the choice to use for cut down? Both looks nice, very little atherosclerosis. Is one versus second, other preferred?
I think the right is usually the straighter shot, usually.
That's why I thought so, yes.
And also ergonomically, in terms of the room setup and everything, tends to be more favorable.
Yep.
You have your C1.
Very good.
Yeah. Let me
So
just
Pedro.
secure the distal artery before I put the sheath down, okay?
Thank you. So one thing we could maybe focus the
C1, please.
surgical area, if to show the audience, we're looking at the
Will you raise the
fluoroscopy.
eye
I don't know
a
if we
little
can
bit
do that, but
Yeah. No, they can expose that area.
expose that
maybe,
area.
Yes.
take away the fluoro right now. Maybe
the
just show the,
baking, or
right? We should just show
resection?
that area of the exposure, that how has
get
been
the suction?
limited cut down. Now, question comes is, some people do percutaneous also, right, with the carotid? Or everybody is cut down? All cut down, okay.
You see the
Yeah,
baking
we're looking
times
at the
two?
area now.
Yeah.
Regarding the access, the data from the
Give me a full set, please.
in Canada, from the Quebec Cardiovascular Institute, is mostly left carotid, like 94%, and very, very few on the right. This access is not that commonly used, but increasingly used right now for the advantages already discussed. But experience is a very important component. Tell us why, Tadros, why did you choose this access in comparison to other non-femoral accesses?
No, I mean, this particular case question is why not the subclavian? There was also a lot of disease, small, calcific, both subclavians, just like what was in the peripheral. Only question is left carotid. The side you know about the left carotid, better
Yeah,
versus.
go ahead and you got the stiff wire in yet or no?
No, not yet.
Let's get the stiff wire in and then I'll get the sheath.
You okay right now with that?
Yeah.
Okay. All right.
No, in this particular
Sahil,
case. Yeah.
Okay, we can
So
exchange.
it was more angulation on the left side,
Yes.
therefore they preferred the right. And I know that some data over
J-wire,
there that
long exchange
some
J?
people prefer the left.
Yeah, actually, in the CT, I look at it, it looks like the origin of the left carotid is severely calcified.
Right.
So that's a very good reason for choosing the right carotid here.
Now tell them to open the camera a little bit so they
Okay,
can
let's
see
get the stiff
everything,
wire in.
not just the.
The other question is, do we
Open,
need to do
more.
When
ultrasound
it opens,
before or not necessarily?
That's why I
Data
secured it.
shows between 50 to 70% doing
good idea.
ultrasound before.
Floral.
It's
Can we
not
bring the CM down?
routinely 100% use.
I mean,
Yeah.
I think for the carotid, you
Okay.
definitely will do.
You want to walk the? I'll hold the sheep. Walk the.
All as a part of the routine workup in these cases. I mean, we are still doing carotid in every case, just
In
like
every
surgeons.
Pigtail,
Yeah,
pigtail.
surgeons want the carotid testing,
got wire.
in
Well, yeah.
patient
wire.
pre-cabbage and
I
so.
got it.
Wonderful.
Yeah. So right now we put a 6 French sheath and the wire crossed with the AR2, and this is
Can you have some wet by 4x4s?
okay. But, all right. So I would just say those who are directly involved keep saying what they are doing so that everybody understand where we are.
So right now we're putting in the pigtail.
So we actually crossed with AR2, then we used a long J wire, and now going with the pigtail. Then we will change to Safari.
One of the
Your
one,
wire.
one of the key things once we're putting in the once we get
Yes,
the
keep
Safari
going.
wire in
Mm.
is how we introduce the big sheath.
Yes.
We want to probably mag out
Yes.
of this view. We want to see the neck. We
Keep
want to
going.
see the trajectory, and also how we hold the wire.
Good.
We want to make sure that we're in line with the with everything.
Little caught
Yeah,
there.
and the reason why you do that is to avoid a retrograde dissection.
Wait. Give me the wire.
Well, you don't want to
That's good.
traumatize any of the
That's good.
vessels.
That's good. Good.
Yeah, we
Retrograde
good, we
is
good.
one possible
Okay.
complication,
Safari.
but vessel rupture, vessel tear, it's a very, very difficult
Okay.
place
Can we map
to
out, please, Sahil?
manage if
Map out
there's a
completely.
major issue.
Show the neck. Yeah. show the
Yeah,
entry
that's an
point.
important
Good.
point on this axis. If you have a dissection,
Okay.
how
Okay,
do
go.
you
Start.
Yeah,
Let me
manage?
pull the
yeah, I
echo
hold in
probe
the
back.
sheep. You walk it out.
And
Let's
for
just-
the
let's try to get
carotid
the wire.
tower,
Can we,
we have,
bring the
and the
angle
same
of
thing for
wire
the
this way?
subclavian, we have a separate delivery catheter.
Yeah, we have the sheep in place. Oh, okay. We have to walk this out. No, we have to walk this out, right? We have
Bring
to
the
walk the
table.
6 French out.
What do you
So
need?
now we are going to move our position.
Yep.
So we'll be perpendicular.
I've got wire.
Yes.
Okay, walk this out. Wet wipe, please.
Actually, we will take. Yeah. We will change.
wipe.
Wait.
So
I'm
Anu,
this
you
way
have the
now.
Confidia wire already there?
No, we have the Safari is already
Safari. We have a Safari
in the
introduced.
ventricle already.
Safari.
So, like
Let's
Rami mentioned, now
Bring
the
the-
challenge
bring
is
the
to
echo probe
remove
back
the
further.
sheath that's already there and then introduce the
Can you go AP, please, on the
The big sheath.
big sheath. So
watch out. Yep.
for that, you see, we're changing our position.
Yep.
Can't
And
be it can't be perpendicular. We got to be parallel.
Aha.
Yep.
You
It's
see
similar.
that?
It's similar to a right
So
subclavian
right now
approach.
we will position ourselves in such a way that he is going to introduce, Rami is going to introduce a large sheath, and then he will hold it, and I'll be the one inflating the valve. Gilbert is going to position it.
So
we
this
are
is
already positioning ourselves.
Let's
like
talk
that.
a little bit about the sheath. Can we show the sheath for a minute?
Yes.
Just here, show this here. This is called a sedative sheath. They use it for transaortic and transapical. So shorter sheath. It's not an expandable sheath. It's a little hydrophilic, but also the advantage of this is that the sheath does not expand, so you don't have to load the valve ahead of time. The valve is already loaded into
Hold
the
on.
balloon.
Let's show how he introduces the
Okay,
sheath.
I want to
Open
release
this.
this wire.
Open.
Okay, let go. Okay.
Okay, and the camera
wire.
come down.
Yep.
Let go of the wire.
Zoom in. Can you see?
Yep.
Hold on. Let them
Yeah,
zoom in.
floral.
Camera up.
You see floral?
Up.
Okay, hold on.
Can you?
Yep.
Or move.
Yeah,
it
we need
away.
the axis, the surgical axis there.
In the wire here?
Eye is
Yeah,
in the
I'll pin it
middle.
up. Go.
No, we're taking it away.
I need to see the screen.
Okay.
I need to see
Sahil,
the.
Sahil, we
Yeah,
need
we
the
can
floral.
see the hands of the
Good.
surgeon now. Yeah.
Yep.
I need to see right here.
Yep.
So I will not introduce the sheath until I can actually see it. Bring
Yeah,
the
you have to-
Echo Pro back, please.
Yep. Yep.
So we want to see that angle.
Go to another view. Go to another view.
Uh-huh.
You have to make sure you have the parallel to the path into the innominate and the ascending. See?
Let me know when you guys think that's enough.
Yeah, I think that's good
No.
enough. Yeah.
Good.
Yep.
Remember, the STJ is way down there, so
Yeah, you're way
that's
too
fine.
deep.
We can pull back, but we can't advance. That's one of the key. It's better to be deeper than
Okay,
pull
can we
back
have more
because you can't
like
push
4x4s?
forward afterwards. Okay.
That's
Okay,
good.
here.
Okay. Good. All right. Okay.
Good idea.
So
So now
now,
I'm securing this sheath. I'm controlling this so that
so I'm advancing the wire to make sure I remain, and then we're gonna walk out the dilator, and there's a hemostatic valve there.
And the average diameter of the carotid is about 7 millimeters, Dr. Tadros. So
I
it
got
can
wire.
handle-
it could
Okay,
it could
here,
honestly be variable. It could be 6 to
Go.
usually I think normal is about 7 to 10 millimeters is about normal.
Okay. Valve, please.
So
Careful.
If you guys see how the wire was positioned, that's very important. You never want to
Now can
advance the
you
sheath with the wire not straight.
Yeah.
mag in so the camera so they can
Yeah.
see
We
how
should
we
go
are
to the
positioned?
and we should get the angle now. Go to the implant angle, please, Sahil. It's LAO 13, Codo 7. Watch your feet.
Camera mag out so they can see us how positioned.
Yeah.
More.
We can do more mag out.
Yeah, camera.
So what are
Okay,
you doing now?
let's-
I see the sheath already in position, but
Yep.
what is the next level?
So you see
Okay.
now we can see here this is a different way it has been mounted. Can you see it?
Oh yeah, the table.
Very
yeah,
small.
absolutely.
No.
very
No.
important.
I
Let's get
have
the
the valve
pigtail
in
in
my
place.
hand.
Yeah.
Okay.
That's
Let's
what
get
we
the
meant,
picture in place.
Okay.
Yep.
Yeah, I see the valve in your hand.
Yeah.
Yeah.
A little bit further down.
Small, tiny.
Pedro, one other thing that we did that I didn't mention, I think is important, is that we actually made an incision on the artery. So we actually made a transverse arteriotomy approximately 30 to 40% of the vessel wall diameter. That's to allow easy entry of the sheath and also to facilitate repair.
Okay,
at
let's
the
show
end.
the valve
Okay,
a minute,
now,
guys. Let's show, hold on.
just
Let's
see how-
show this. Okay, this is important. You can see there's a loader cap here. The valve is coupled into the certitude sheath, but you have to de-air, right? Because there's a little plunger here, de-air when you couple. And you have to make sure you take this out at the same time at the end, because there's no hemostatic valve here, otherwise you're going to splash everyone. So you have to make sure you remove that at the end of the procedure.
Now
So,
just see how they're going to introduce.
so you can see,
We are
and,
parallel.
and the nice thing, there's also a little bit of flex here,
Yeah, I will. You hold it, not done yet. Okay.
faces the balloon, so you can see the direction. He's going to insert it in there now, and you can hear a click. Click.
Not yet.
Go. Push.
Yeah.
You hear a click?
Yeah, I think so.
No.
No, I got it.
Okay.
Yep. Yeah, you see it. You see it. It's a click. Yep. You can see it right engaged there. Okay.
Yeah.
So now you go to the air. Actually, just make sure you hear that.
Camera is.
It's camera. Can you
Okay.
move the camera? They
Yeah,
can't see.
I up a little
Oh,
bit.
Raise the
Where
camera.
we can see.
Yeah, here.
Yes.
Yeah, and can you everyone see now? You
Yep.
can see?
Yeah.
Yeah, we
You
can
have that
see.
little plug? Okay, good. Okay, so now we're going to look at flow.
Yeah, thank you.
Okay.
Advance.
Damien, can we bring the fluoro closer to us,
You have the
please?
wire, right?
Yeah, I have the wire.
Okay, so
Can you hold the
yeah,
wire?
yeah.
Tadros, your left hand, can you show us a little bit before you go in?
Yep.
If you
Yeah.
remove your left hand for just 1 second to see the whole thing.
Yeah.
I'm not going to do that.
Possible?
No, you
that
can't.
one,
You
no.
can't.
That's
Okay.
fine,
Yeah,
that's
I-
fine.
yeah,
That's fine.
Damien,
That was
need to
that was
rotate
actually
it
a test. I
facing
think.
us.
Okay.
Dr. Moreno's testing me today.
Yeah, where's the pigtail?
We'll come down.
Go, advance.
Okay, so he's across the valve now, and
Yeah.
I can.
We
He's
need,
going to
need to
exit the
go to
sheath.
fluoro now. We need to go to fluoro now.
Okay,
Yeah,
now
we are
to the
fluoro,
floor
okay.
also. Yeah, good.
Okay, so he's going to cross the valve. You can see the bottom of the pigtail. Good.
No, we don't see
Keep
any,
going.
we don't see the fluoro.
No,
It
you
Yeah,
is
are-
now we
okay.
see it. Now we see
Okay,
it.
mag in now, please. Mag in.
Okay, now you want to
Okay,
bring the
good.
sheath back
No,
up. Sheath
The
back up.
sheath needs to go back a little bit now.
Let me know when you're
Yeah.
happy.
Yeah, advance the
More.
valve. Yeah, advance the valve a little bit more.
Okay.
Okay.
And I'm going to flex to help you because we didn't pre, right? So, Yep, go ahead. It's a horizontal route.
Okay, I think you're okay now.
No.
Okay, some dye, pigtail.
Did you cross yet?
There you go.
Yeah, now we did. Yeah.
Not too much. Not too much.
Yeah.
It's good.
Yeah. Okay, good. Can I bring the pigtail down? Okay. This is the angle, right? Yeah, okay. Let's bring the II down a little bit so we can see properly. Pressure is okay, Joe? Good. Okay, good. Let's mag in now,
II down.
please. And II down, please. No, table up, please. Yep, mag in, please.
Good.
So let's see, we have to fine adjust the actually, it's not bad.
Very good. Yeah.
Okay, mag in one more, please. So the flex helps a little bit because remember, we talked about it's horizontal aorta, right?
Okay, now
Good.
Does everyone agree?
180.
Everyone's okay?
180.
Off.
When you say off, just disconnect, not go up and down.
Okay, try again.
Okay.
Off.
Looks very good. Okay.
Good.
All right.
Okay, 180. I'm going up. Hold everything. Hold the wire.
I'm
Hold
holding the wire.
Really hold the
Okay, I
wire.
hold the wire. Okay, it's pacing.
Okay, going up.
Okay.
Push forward a little bit. Yeah, good.
Okay, full.
Yep.
6.2.
Yep. A lot of parallax there, you see. Okay.
Just
Okay,
parallax.
we
Shoot
can.
again, yeah.
Okay.
Okay.
Off.
Good. Okay, let's take the parallax out and do an aortogram. Blood pressure is coming
Pacer.
up nicely.
Yeah.
Yep.
Pacer is off.
Pacers
no,
80. Pacer 80.
80.
Yeah.
Nice. I like that.
Okay,
shot.
get the
Good.
pigtail down.
And let's see where it is. Yeah. Good. Yeah.
Good.
Let's
Nice
do the
high
aortogram.
implant.
Okay, good. Go, Cine.
Okay, Cine.
Pigtail in.
Perfect.
Nice.
Okay,
Perfect.
good. Okay. All right. Back up, pacer, please.
This has to disconnect first, right?
Yeah,
Yes.
that's right. Okay, so next step.
Hold on,
gonna,
hold on. Now let's open the camera and let's see how we come out.
Okay.
Okay.
Show the hands now.
Back up the
Okay,
camera.
so
My question is,
first-
do you want to just pull back the wire or no?
Yeah,
From the ventricle.
Yeah, we done the wire, right? Yeah.
Yeah.
We
Yeah,
can pull back
we'll,
the wire.
we'll
Okay.
pull the wire back.
Yeah.
Pull the wire back first. 1 second.
Wire back.
Leave it off.
Good.
outside
Okay,
the-
there,
yeah,
leave
right
it there. Okay, now we're going to walk this out, and then I'm going to disconnect. Okay, hold on. Yeah. So there's a little latch there. So you have to disengage. See the loader? Everyone see that? Here, let me
Yeah,
show here.
yeah,
You see that?
yeah,
Make sure
yeah.
this is out.
Yep.
And then you take everything out. Leave the wire, right?
You can take the wire out.
Ram,
Take the
you
wire
want
out.
the wire- wire or
Everything
no?
out. Everything out.
You want the
Okay,
wire?
good. No, everything out. Good.
Nothing I can do with it.
Yeah.
Okay.
Good.
Okay.
That's it. So that's the procedure. Now, what's very important, this sheath is different from the E sheath. So I know a lot of people doing carotid access, you like to use the commander system, the E sheath. We don't like it for two reasons. One, the E sheath can split. So when you remove the E sheath, it's longer, you can actually have an issue with bleeding.
Okay.
Two is that the commander system is much longer for femoral, so it's much ergonomically difficult for people to be standing away from the patient to actually do the implant. So and you also have to load the valve, preload the valve,
Yeah.
right, in the patient, which sometimes you can see the aorta is short. You might not have that runway. So for that reason, we rarely have any issue with the cervical sheath, and we really, that's our preferred approach. Marmy, any comment on that?
No, I agree with you 100%. I think now the sequence of events is we have a vessel loop that's tense on the distal vessel. I'm going to replace the vessel loop with a clamp. The vessel loop tends to put a little traction on the artery and kind of opens up the arteriotomy more. We want to kind of relax that. And then the one thing you never want to do is, lose control of your proximal vessel into the chest, because we are very close to the clavicle. So because the patient has actually some cervical spine disease, the neck is flexed rather than extended. So I actually put a retention suture as a safety measure, just in the event we lose the proximal vessel, that I actually have a suture on it so that I can bring it back into my field to reconstruct. So this is just kind of a safety that I put here. And so now what we're going to do is I'll have my fellow Dr. Bill Zickler come back in. We can actually take the fluoro out of the way, and we're going to actually retract I'll first clamp the distal vessel, then I'm going to take the sheath out under vision, and I'm going to clamp the proximal vessel to do the repair and the reconstruction.
Yeah. Stan, can you tell us how the echo looks now, maybe?
Yeah, the echo looks great.
Can you show us the echo, please? Thank you.
As you can see, perfect position.
Yeah, let me have the focal hydrogrip too, just in case. Okay.
No
debate keys
PVL,
times
no
2.
PVL.
Hey, who's
I'm
moving?
a little worried here because
Camera. Don't
And we'll go to the stomach to
can I have
measure the
hold this
velocity.
here in place? Can I have another small wheat liner?
Okay. So yeah,
Done?
so now we don't need.
Okay, so
echo
show
is
this
good.
other camera.
Valve is good.
Hold this
Yeah.
over
The
here.
gradient AI anything.
So when I saw
No
it,
AI, no
Mr.
AI.
Good.
Artery.
I'm going
Beautiful.
to the stomach.
split,
Yeah,
Okay.
short axis. Yeah.
it kind of
Yeah.
split.
So what we'll do is we'll
Downwards
continue.
rather
Dr.
In the
Tadro Remy
camera.
will continue to do the vascular closure now, and they have their own technique. And now compared to, as we know, that a lot of people are doing axillary now rather than subclavian percutaneously.
Yeah, hold this just
Also
gently.
some cut
We
down,
don't want to lose that
and
distal
of course
vessel
the
there.
carotid. All
that
cases are
down
with the
there.
cut down. Those are the alternate
the
access.
sheath just
Other
a
one
little
is
bit
vena
back.
cava. There is a nice review article last month in the Jack on the vena cava
Debating.
access. But more and more people I'm talking. Gilbert, what is your sense? People are going away from vena cava.
This way.
Well,
Cable
I
access.
think you want one
hand is
alternative access that you're good at.
Yeah.
I think that's the key because
Uh,
so
let
few
me see
now.
the-
I mean, last year we did only one carotid
Yeah.
over 500 plus cases. That's like less than 1%. So if you're not good at what your preferred technique, that's when complication can happen.
Okay.
So whatever we like the carotid, that's our preferred approach. Other plate pieces have tried suprasternal, transcaval, axial, whatever they prefer.
Okay, beautiful. So while this process is going on, let's come to our presentation, and we talk about we actually some little bit. I want to take it from where I left last time, or the bioprosthetic valve fracture in valve and valve tower, then coronary obstruction and protection in valve and valve, as well as native AS tower, and the Swiss TAVR registry of balloon expandable versus self-expanding valve in the small annuli. So basically, the bioprosthetic valve fracture. I did speak about the presentation which was done in ACC. Now it's a full paper with Garcia and Chatriwala in Jack intervention last month. And basically, what showed that we do the BVF, that is the bioprosthetic valve fracture in 21% of cases. And what basically looked into is the two aspects. One, where you do a BVF. Second, you do pre or post. This also always has been an issue. Do you do a pre-implant or post-implant? And so basically showed that anytime you do BVF, these are various, of course, higher length of stay, little higher contrast volume. But more important, that once you do BVF, you have a higher mortality and higher life-threatening bleeding. And other complications tended towards higher. So key is that the BVF is bad. If you cannot avoid it, if you can avoid it, it's reasonable not to use. Now, this is basically the second point. This is the in-hospital and 30-day. The BVF, the question is pre-implant, BVF versus no BVF or post-implant. And you can see here, the pre-implant is having more complication compared to the post-implant, which is on the top side, the no BVF. Then what is the advantage of the BVF? That is, you get a better valve area and lower residual gradient. So this is where we are really shown. Sahil, you want to talk? Oh, but you don't have the appropriate one, right? Yeah.
And
Yeah.
SS, why
Yeah.
do you think this is happening? Why the BVF is increased mortality?
Yeah, so I think what it does is that very high chance of coronary obstruction. Because remember what happened is the same fixed annulus and is associated with higher, some cases the leaflet derangement, leaflet rupture. We actually one case created a lot of trouble and require urgent surgery post, but most of the data support post BVF and higher mortality just because these were the cases with the small annuli. The question is that why BVF has a higher mortality compared to no BVF cases, but clearly we do BVF in a patient with a small annulus, and that's why you're having a more complication, a little more rupture, and a higher coronary obstruction.
Yeah, I think this is also the balloon expandable valve, right? There's another presentation from ACC, I'm sure Dr. Sharma will mention, with the self-expanding valve that tells a different story. So I don't know what kind of signal there is, but certainly it was it got a lot of buzz when it was presented last year at TCT.
Yeah. And so same thing, that if you do post is better. This is where they shows with a self-expanding valve, as you can see here. So key is that any BVF, higher mortality, higher aortic valve area, and lower gradient. but also higher bleeding, we understood. Now, if you have a pre-implant BVF versus post-implant BVF, clearly you can see the post-implant is better, does not increase mortality, and gradient decreases. So this is basically is with the self-expanding. So question also comes, we are acutely doing such a high pressure on the newly introduced leaflet. What will be the long-term effect of the valve durability with the BVF? That's the question always comes, that what will happen in these patients. Gilbert and Anu, you want to comment on it? So we're clearly using a high pressure device, a high pressure balloon. You are causing some damage. There are some data in the tissue, more of a animal data, and so that you cause more calcium deposition by doing this kind of a valve, putting a high pressure on the newly valve.
I mean, we have been doing post, right? Post on TAVR cases. At least 30% of the cases we do post. So I think it's the same concept. Probably nothing. I mean, the way these guys have made this valve is so good, should not have any effect. We should have seen something.
Yeah, I think
you're
trading off between, the valve being constrained and your pin ruling and durability, or leaflet injury, what you mentioned. So we don't have the answer, but we'll find out hopefully, with some longer term data.
Yeah.
But
yeah, see microfracture. Yeah, actually there is a paper just came out from the Vancouver group looking at some of the balloon valve fracture effect on microscopy and histology, and show that there is some differences if you fracture before and after, and also some damage, microstructure damage on the valve.
And another big issue in this is the coronary obstruction.
Yes.
Now, compared to various procedures which you do, now there is a new device, the leaflet direct cut. Hopefully will be, when did you think
shortcut?
Will come to USA?
Yeah, so they started a trial in the United States already, so we'll see when it will be completed. So, we are the part of the Data Safety Monitoring Board, so we're not part of the study.
That's the shortcut for the leaflet. That is one of the biggest issue.
Yes.
So then question is, the whole issue from the fracture give rise to coronary obstruction, and there are a lot of issues. We actually were the first one, issue about the coronary access and so. But key is at the time when you are deploying the valve in the native, as well as I talk about the native as well as the valve in after the valve degeneration. What are the predictors of coronary obstruction? This is a nice paper from the TVT registry with the obstruction versus non-obstruction. You can see, and they have a matched population, and obstruction does occur in a small percentage of cases, about few percent, and basically it occurs from two things. One, from the sinus of Valsalva totally compromised, and secondly the leaflet comes up. So those height, so aortic annulus, leaflet tips, and of course the commissures and the sinus of Valsalva, the width, all very important, and that you can decide based on the angiogram. And how often we will say the borderline case, Gilbert, that should go for surgery because there is very high chance of coronary obstruction.
I think the issue is that you can't predict it as well as you think you can. I mean, we actually talk a lot about not using just CT, but an angiogram, right? We go to the cath lab, go to what we call 2-1 view to look at the angiogram, the leaflet. Sometimes, remember the CT has artifact. If the CT has artifact, then it's not useful. And we actually been pleasantly surprised that we can do the case, right? When we do the cath lab, or vice versa, that it looks good on CT, but doesn't look good on cath. So you have to, and that is also important, redo TAVR as well. But sometimes with the balloon expandable valve, remember, like it can flare outward. And if you fracture, you don't know which way it's going to fracture, which way it's going to go in the left main or the right or non. So that's the question mark. That's why I think the risk is higher. You just don't know.
Dr. Tang, is there any absolute height of the left main in which you must protect?
So we looked at Pedro has a great question, because remember surgeons implant about supraannular. So the left main or the right will always be lower than native anatomy. So we looked at the sinotubular junction. If your leaflets are going to be above the sinotubular junction and the STJ is small, that's a problem because you're going to close off the sinuses completely. So that's what we look at actually.
And of course, we know the left occludes more. And actually, by this TVT registry data, both self-expanding and balloon expandable were equal. And of course, as you see, some of those things which you just asked right here, Pedro, that one, the annulus that is smaller, and left coronary height. I think basically it is 11 millimeter in the literature. Some people say 10. So 11.
We have gone
10.
lower than that.
Huh?
Yeah. No, I'm asking him. We have done lower than that.
Yeah, we've done lower. Yeah, much
Yeah.
lower.
That's why I think Pedro's question is what is the cutoff now?
the
I know
sinus height
when literature is 10 and 11, but we have done as low as I remember 8.
Yeah.
7 we have not.
Yeah, yeah. Native is different. Correct.
Yeah. And sinus, the sinotubular junction, whether 30 or annulus dimension. So as you can see, right corner is about 15 and left is about 10. That's where the trouble occurs. Now,
so to clarify a little bit, so the below 11 you must protect. It's not that you have to send for surgery.
No.
It's that
No. Yeah. You look at the leaflet height, I think, and the sinus. If you have a lot of big sinus, then left main 11 is okay. But if you have very small sinus, left even 12 is not okay. So I think we look at it on a case. 3-dimensionally, we can look at it. But I think at Mount Sinai, we have not had a coronary obstruction for at least 8, 9, almost 10 years now, actually, because we planned all this ahead of time. So, remember, and also this is very rare.
Gilbert, I think we can have obstruction, but we are prepared to fix it with the
correct.
stent.
That is correct.
Absolutely correct. We had cases where we know we preemptively need to intervene because what we call the white line sign, right?
So key is that we decide based on that coronary protection. One, just put a wire preempting, and if we think that there is a much chance of obstruction, and what is basically simple is your 11 millimeter and 30. Less than, if both are there, then you have higher chance. One is forgiving, the chances are lower. So sinus width and the coronary height combination is the one. So right coronary, just because of the height, has a lower obstruction, and we have done very few right coronary protection.
Never.
Like 1 or 2. No, I think we did one or 2. No,
maybe one, but maybe a valve in valve.
Yeah, valve in valve case. It's the right coronary, but otherwise it's the left, which is the troublesome. So if the combination of a simple rule, 11 or 10 and 30, both are negative, that much chance, and this have been shown by various the logistic model, and this actually is a nice their central figure that clearly once you have a higher the coronary obstruction, coronary obstruction, your mortality is 26.7 versus 0.7. Look at this. What will be the odd ratio? Is a 30 times higher mortality if you develop coronary obstruction, and annulus dimension, coronary height, sinus of Valsalva, and residual sinus Valsalva width, and sinotubular junction height and width, all are predictive of various propensity match made a nice model to come up that which patient could have higher chances of obstruction. They went beyond just the annulus and the height in this particular paper, coming with the sinus of Valsalva, then residual sinus of Valsalva, and few other points, the threshold, and the leaflet calcium. That is also first time they showed that calcium volume of more than 600 millimeters square was associated with higher chances of obstruction. And so basically a novel computed tomographic based multivariate prediction model that can be implemented routinely in real world practice predicted coronary artery obstruction for TAVR in native stenosis. And the basically is that clearly making process that sometimes we do the TAVR in these cases, and its issue is both the leaflet and the sinus. So they called it a direct obstruction and the indirect obstruction. That sometimes you have the displaced leaflet sequestering sinotubular junction. That basically means what? It is just a short, a small sinotubular junction. Or
Yes.
Yeah, the leaflet may not be long, but it's a sinotubular junction is so. Now then there is a one valve which is very nice paper on that, that when you do a valve in valve, and there are two types of valve. Internally stented surgical valve, which is basically the suture is outside, and what it happens is in a small aortic orifice, by using this internally stented surgical valve, because they give the better lumen, better area acutely compared to your other surgical valve where the valve is implanted outside the inside. So tell us a little what about for us from interventional point of view, what is that internally stented surgical valve? We say that valve is implanted outside versus inside in the other valve.
Yeah, what that means essentially is what we call in surgeons externally mounted.
Yeah.
The leaflets are mounted outside the frame. It's kind of the same. And what that does is a kind of higher risk of coronary obstruction, as we know, with valve-in-valve TAVR. But yes, the gradient are lower initially, but we know that both valves is now to fail early. We see a lot of our valve-in-valve actually are composed of these two particular type of valves.
Yep, very important. So initially looks better hemodynamics, but they have shown one, higher degeneration,
Yes.
and secondly, once you do the valve in valve, higher coronary obstruction in this stented. So this is basically showed another, our data from the TVT registry that patients who have valve in valve, they of course criteria, height, virtual valve, shallow sinus of Valsalva, stented surgical valve, presence of leaflet, calcium, all of them decided that there is a trouble. You start with a coronary protection, and of course the valve is deployed, and otherwise guide the way which we have shown few times in our meetings here. And the question is which case you require, and this is actually very interesting that anything which you do, bioprosthetic valve fracture, balloon expandable valve, internal diameter less than 19, and internally stented valve. So you see here the surgical valve. If you're doing a TAVR in these cases, internally stented valve on the left side, mitral fluid trifecta, and coronary obstruction is in almost half. If you don't have internally the stented valve, the coronary obstruction is 3%. So this is a big difference. Now, even then, we know how to take care of it. So therefore, outcome at 2 years was 2-3 years was no different. But predictors of coronary occlusion were valve fracture, coronary height, balloon expandable TAVR, true internal diameter less than 19, and internally stented valve and virtual valve to coronary distance. So what exactly was, I couldn't understand much on the virtual valve to coronary distance. They say they made a, it's a more of a computerized program, and they give you, there was a number into it, like less than 4 millimeter or so. Yeah. Virtual valve to coronary distance is less than 4 millimeter. It is again a computerized program that tells you that higher chances of occlusion in those cases. So therefore, it basically is that we truly, this is the internally stented valve, so much so that the nice editorial, you say, internally stented bioprosthetic valve should not be used anymore. So clearly more degeneration, higher, but within 5 years, there's almost like 10 to 12% degeneration. And more important, once you start doing a TAVR, this is trouble. So anytime when patient we send for surgery, we tell them not to use it. What is the instance? How much we are using internally stented
We
now?
rarely, they don't have them in, mitral fluid is no longer in use, and then trifecta, they're still available, but we don't rarely use those now, especially with the new Inspiris, which has a hinge, allow you to expand with the new TAVR, valve-in-valve TAVR. That could be an attractive option in these patients. They can put a larger transcatheter valve in the future when the surgical valve fail.
So one of the advantage which they say, otherwise if you don't use the internally stented valve, surgeon has to enlarge the aortic root and then put a bigger valve, because these are the 18-19 millimeter annulus.
Right.
So this is where the technique, that's why people used to do it in the past, but now so they say Edwards Inspiris Resilia. So key is that those are all these things, and new things are happening. The last my presentation is in a small aortic annulus, less than 430 millimeter square. That's what they call it, aortic annulus. This is from Bern and Swiss 5-year outcome of the self-expanding versus balloon expandable, and so basically showed overall the individual, most of the patients they use self-expanding had a little more higher comorbidities, but these were the data. That is, technical success was equal, more paravalvular regurgitation, as you can see with the self-expanding versus the balloon expandable, and say prosthetic patient mismatch was a little opposite. Higher with the balloon expandable versus self-expanding, and the device success and technical success were equal in both. So key is the acutely there were some difference, and more importantly hemodynamics. There was a lower gradient when you use a self-expanding valve compared to balloon expandable. But what happens? It looks like you have a lower gradient, but at follow-up there is no difference. Actually, if you see, balloon expandable actually have a lower mortality at 5 years and definitely lower stroke rate. clearly in the small annulus, and this is a very important point. So although it's statistically not significant, but significant was the lower stroke rate, and trend towards p-value was 0.2, but 5-year mortality with in the small annulus. And this basically, some echocardiographic and hemodynamic changes we know, but do not translate into a 5-year outcome. But we have 2 trials, and we are part of the SMART trial, which has been completed, 716 patients, and results to be expected next year in TCT. Then there is a BEST trial, also comparing all, apparently has started, and that will tell us about that which valve is better, because this is where the field is. So let's complete it, and we are getting to a point that bioprosthetic valve fracture should be reserved for selected cases of small surgical valve, as is associated with higher adverse outcome of short-term mortality and major bleeding. Post-TAVR BF has lower complications than pre-TAVR BF and provides better post-TAVR hemodynamics. Second, there are various aortic valve, sinus and annulus characteristics which are associated with coronary obstruction, commonly of left coronary, and is associated with significantly higher short and long-term mortality. Internally stented valves have poor outcome of degeneration and higher coronary obstruction. Valve leaflet fracturing devices soon will have a role in preventing coronary obstruction during TAVR, this shortcut. The device. Both self-expanding and balloon-expandable TAVR have different procedural outcomes in a small aortic annuli, with lower residual gradient and higher PVL and lower PPM with self-expanding versus balloon-expandable. There are no differences in mortality outcome after any of these valves at 5 years. A SMART randomized clinical trial will give the final answer on this. So let's go to 3 questions. Following statements are correct. For BVF, there is no BVF during TAVR except means which one is wrong. BVF is associated with higher mortality. BVF is associated with the higher bleeding. Post-TAVR BVF has better outcome with lower gradient, and pre-TAVR BVF is associated with a lower mortality. Answer there is the D is wrong. Pre-TAVR BVF is associated with lower mortality. No, higher. So post-TAVR is good, not the pre-TAVR BVF you do. Following statement is false regarding the adverse predictors of coronary occlusion during native AS TAVR. Aortic annulus dimension, coronary height, low leaflet calcium volume, and sinus of valve salva width. Clearly, you have high calcium, which is the problem, not the low calcium. Then third question, following statement is true about the Swiss TAVI registry of a small aortic annuli comparing self-expanding versus balloon-expandable valve. Balloon-expandable valve has significantly lower mortality versus self-expanding. Self-expanding valve has a lower post-procedure gradient versus balloon-expandable, and self-expanding valve had a lower PVL versus BVV, balloon expandable, and balloon expandable valve had a lower patient prosthetic mismatch versus BV. Answer is B. Self-expanding valve has lower post-procedure gradient versus, but everything else is wrong. So with that note, we are completed with our presentation, and Remy also tell us, Dr. Tadros, where are we now in terms of your closure of your aortic or your carotid?
We're almost done with the closure. We have to just tie 2 more sutures. Do these 2 needles here. And then we're going to do a completion angiogram in about 2 minutes.
Okay.
We have 2 minutes?
Yeah, we have it. I think that we should show that.
Yes.
So question is, with all this data, we were quite excited about this balloon, fracture and so. More and more, I learned by reading the literature, they say that we should be away from it.
Well, I think because they're so, we are sites that do a lot of TAVR and do a lot of valve emulsion, know how to do that. I think a lot of small centers who do maybe 50 TAVRs a year, they might not even see 1 valve in valve a year. So I think they're not used to the cadence. And a cardiac anesthesiologist is excellent, right? In terms of anticipating there might be a QAR or other issues that can support the patient before we implant the valve. But also ACC 2023, that they look at the self-expanding valve from TVT registry, there was no association with mortality. So I think it also depends on which device and how you do the procedures. But, I do feel that if you can fracture, it will be, I think we can do it safely, at least in our hands. But I think you do have to be aware of the points that you brought up.
So now question is, if you want to avoid fracture, should you put a self-expanding valve?
Well, I would definitely suggest that as long as you don't have coronary obstruction risk, and also we have done before we fracture, post-dilate gently, just to expand the frame a little bit, not fracturing, just so that improve the hemodynamics, because we know there's, at least from a surgeon standpoint, for surgical valve failure is different from native aortic stenosis. Surgical valve failure, the leaflets are very non-compliant. Very difficult to cross, as we've seen in terms of the crossing the surgical valve versus a native valve. So I think there is some benefit, or maybe just balloon and the internal diameter just to expand a bit more, but not fracture. That I think we can safely do.
So let's say in age of, I mean, young age, you definitely want to send patient for redo surgical valve. Patient is 75-year-old. Which characteristics of your the bioprosthetic valve degeneration patient you say, you know what, you should go for second surgery, even if the age is over 70, 75?
I think that the challenge is that if you have severe PPM,
okay,
and you
so
cannot fracture,
yeah, so it's small valve, so
exactly,
19 or 21,
exactly, 19 to 21. I think those are the most common, that you have severe PPM.
That together.
You put a TAVR in, it's not going to make you feel better because you cannot fracture to expand the internal valve. That's probably the number one. And then if you have coronary obstruction and you don't have shortcut, you don't have basilica, you don't have other snorkeling available, then I don't think you can do the case, technically speaking, unless you have patient with previous CABG with all three territories bypassed. That we have done with valve in valve TAVR, even with coronary obstruction risk, as long as the native coronaries are not, already occluded.
That's
beautiful.
Yeah,
looks good, right?
Okay, so I think this field is, because more and more people are coming now, patients, of course, with the surgical valve. Now they're coming down, and rarely they are, many of them are going for the TAVR, valve-in-valve TAVR.
Actually,
and now we actually have about a handful of cases of the TAVR degeneration putting a second TAV in TAV.
We'll get ready for
That's another field.
okay,
So now we are ready to do an angiogram.
Can we go back to show fluoroscopy, please?
Sorry, the whole thing.
Yeah, DSA. Can you go DSA, please? Okay, 1 minute. Can you T probe up, please, Stam?
So we can take away the hands. We don't need. We just need a fluoro now.
Yeah. Okay.
Yeah.
Let me see.
We just put the fluoro. We don't need the side, right?
Yeah. Okay. Yeah.
Yeah.
Guys, ET tube. I'm sorry, the
T up.
TE up. Yeah, all the way.
Yeah, yeah. You want LVO? Yeah, let's do LVO.
That's good.
Watch your
there.
feet. Watch your feet.
You want to get out there? You want to get out?
Can we just do the fluoro alone in the full screen or no?
Yeah. Can we do floor? Yeah. Okay, you want the pigtail to be close to the arch, right?
I mean, they always have to have double screen.
That's good right there.
Yeah. Good. Okay. Ready? Okay. Ready?
Let me just make sure this is loose.
Yeah. It's loose, right? He's just checking to make sure.
Okay, good.
Okay. Well, it's pretty much where we are already.
Yeah, we're good.
I think we're good. You ready?
And
Okay, go.
you wanted to inject at the
Yeah, they're doing it
origin
now.
of the great vessels?
Yep.
Okay.
You do a breath hold.
No, you can see.
What
You can
happens?
see.
Let's do one more AP and
Okay.
breath hold.
Okay.
Can we
Lungs
get a
down,
breath
please,
hold, guys?
Joe. Lungs down, please. Ready? Okay, go. Need more injection.
Very
Beautiful.
nice.
Wow.
Oh, this was a
Okay.
bovine type.
It was a bovine.
Yes, it was a bovine, correct.
So any comments on those, Tadros, with perfusion for the brain when you occlude both?
You know,
With
I
the
think
sheath?
that usually when you have a bovine, it's a very large ostium.
Uh-huh.
In this case, it's almost 2 centimeters. So we're putting in, an 8mm sheath and a 2 centimeter vessel. It should not be obstructive. Even we had an A line on the right side, and even the right-sided A line maintained its pressure, even with the big sheath in.
Thank you. See you there.
So
See you downstairs.
that just goes to show the size of the innominate artery, especially in the setting of a bovine.
Beautiful. Beautiful.
Thank you.
It's an excellent.
case. All right. Very good.
All right,
Wow.
okay.
Let's go ahead and give protamine.
Yep. Fantastic. So, Pedro, you conclude now, or today's fantastic session of the Trans-Carotid?
No, we're done.
Yeah, absolutely. This is a fantastic day. I mean, it's an unbelievable demonstration of perfect technique
Much come on my side.
with beautiful step-by-step, and most
Sure.
importantly, the
That's fine.
teaching component of Dr. Sharma was unbelievable. So thank you very much, all of you. Remember that this case and all the other cases are available at www.cclivecases.org.
The
We
last
do
time-
our in vivo heart valve cases the second Tuesday of every other month. It's 9 a.m. So the next one will be Tuesday, June 13 at 9 a.m. Thank you so much for joining us today.